uma marca histórica na substituição da válvula aórtica transcatéter.
Boa noite a todos. Esse webinar vai ser feito em inglês, todo ele, e tem a cooperação entre a Sociedade Brasileira de Cirurgia Cardiovascular e a Medtronic. Good evening to all. I would like to thank you first, Professor Herrmann, for being here, as well as Professor Eduardo Saadi and Professor Alexandre Siciliano Colafranceschi, and also my co-partner, which is Professor Manuel Almeida Brandão. I would like also to thank personally Juan Gaspar for making this webinar possible and for being responsible for the Medtronic part, and also to Medtronic as a whole for giving us this opportunity to discuss one of the most important things in Tavi nowadays, and which we'll be discussing further on, which is the difference, or which is the appliance of the Tavi or TAVR for small annulus in all patients. This is a very important subject, and for that I would like to invite Professor Howard Herrmann to start his presentation. He'll be speaking about small annulus clinical study, which is SMART, the trial that started, which is in the clinical trials in the January this year. It's about to start with 700 patients, and we'll compare the Medtronic valve Evolute with the Edwards valve, the Sapiens. So there's no problems with the conflict of interest of defending one of it or the other valve, because this study will bring us the truth about which is the best valve for that. Professor Howard Herrmann is Professor John Wigfall, Professor of Medicine and Surgery at the Paramount School of Medicine and Health System, Director of Interventional Cardiology, and the Director of the Cardiac Catheterization Lab at the Hospital University in Pennsylvania, Philadelphia. It's a great pleasure to have you here, and the floor is yours. In this case, the screen is yours.
Thank you so much. It's a real pleasure to join you tonight, and I want to thank you for the kind invitation and for Medtronic for sponsoring my participation tonight. I will take over the screen if I can here. So thank you for the invitation again, and I'm hopeful that I can share with you some of my thoughts on hemodynamics as they affect TAVR, specifically as they affect the small annulus and some of the rationale and design for the TAVR trial. I run the TAVR program at the University of Pennsylvania, where we do about 600 TAVRs annually, utilizing, and we've been involved right from the beginning in the partner trials in Tavi, and we utilize primarily the two commercial valves, and we're also partake in a number of trials. And I'd like to just share with you some of the data that I think is of interest here. These are my disclosures, which include some honoraria and consulting fees from both Edwards and Medtronic. So this is sort of a summary of what I hope to share with you, some of the hemodynamic caveats. Optimal hemodynamic performance is, of course, key to both clinical outcomes and long-term durability. Most studies have used echo, and although they have demonstrated superior hemodynamics for self-expanding as compared to the balloon expandable valves, we know that echo actually doesn't measure gradient, it measures velocity, and as such, it does overestimate slightly the true gradient. Nonetheless, I think echo gradients are the gold standard for long-term and sequential follow-up, since we can't measure hemodynamics invasively on a recurring basis. There is a discrepancy between the echo and hemodynamic gradients, and that's partially explained by the concept of pressure loss recovery, which I'll review with you. But in general, that only plays a small role in patients who have mild aortic stenosis, such as those who are after TAVR. And if you do measure hemodynamic gradients, it's very important to measure them rigorously. You need to use end-hole catheters. One catheter must be in the ascending aorta, and you have to account for the post-procedure low-flow state, as I will share with you shortly. Adverse effects of high gradients, low effective orifice area, and severe PPM are going to be most prominent in the 20 to 30% of patients who have a small annulus and receive small prostheses. And importantly, 90% of these patients are going to be women. So this is an area that's been underrepresented in randomized trials. Women have not made up the majority of patients, but in the small annulus population, they do. And that may account for some of the differences that have been observed in how TAVR performs in men and women. And this is the rationale for the SMART trial, and I'll share with you the design of that trial. So let's do this in terms of some questions. And I have 4 questions that I'll answer for you with data. The first is, what is this controversy between invasive gradients and Doppler gradients after TAVR? Are Doppler gradients accurately reflecting the hemodynamics associated with an implanted bioprosthesis? So we know that echo measures velocity, and it's a proxy for pressure. It measures the velocity of blood flow, and then we take that velocity and utilize the simplified Bernoulli equation of 4v squared to derive the gradient. And considering that velocity is squared, it's important that that measurement is accurate. So pressure loss recovery partly explains this difference between echo and hemodynamics. Pressure loss recovery is a hydrodynamic phenomenon. It's an engineering principle. As the velocity of blood increases along a tapering flow field, as you see coming out of the ventricle, and as it converges on the stenotic aortic valve, it will increase in velocity. And that increase in velocity is accompanied by a decrease in static pressure. So here you see the LV pressure measured in the cavity of the LV. And here you see, as you pull back a catheter from the apex toward the aortic valve, there is actually a fall in the left ventricular pressure. This is pressure energy converted to kinetic energy. Distal to the vena contracta, which is the point just after the aortic valve of the highest velocity, and this is where the echo measures, the continuous wave echo measures the velocity. This is the point of maximal velocity. As you get past that distal at point D, and there is recovery of pressure as the kinetic energy is converted back to pressure. And so you see the aortic pressure here increases again as you get into the ascending aorta. This is the concept of pressure loss recovery. If you just measure echo, you're going to overestimate and not account for it. If you measure hemodynamically, you have to measure it here, and not over here, and not with a pigtail catheter that averages that pressure over the LV and the aorta. But it's also important to recognize that pressure loss recovery and the amount that echo will overestimate the gradient is most relevant when flow rates are high, when the aorta is small, and when the jet is highly eccentric. Most of these are not present post-TAVR, so the amount that pressure loss recovery accounts for a difference in the post-TAVR mild AS patient is relatively small. You've seen slides such as this that have measured hemodynamic gradients and shown that they are lower than the echo gradients. The hemodynamic ones are in blue and the echo gradients are in red. And this is true. There is going to be a slight difference measure them hemodynamically. But if you do it hemodynamically, you have to do it right. You have to have 2 catheters, same length, balance, and transducer sensitivity. Pigtail catheters are not ideal for this. Single lumen catheters are best. And the best are actually high fidelity micromanometer catheters where one is in the LV and the other one is pulled back. This is the kind of thing that's been shown at meetings. Here you see on the left an echo gradient of 27 and the same patient with a hemodynamic gradient of only 18. But if you look at these, you can see that these are an average of 4 beats, none of which are the same, some of which are not corrected for time delay, for systolic augmentation. They're often measured at the femoral sheath rather than in the ascending aorta. So one has to be very careful when you do the hemodynamics to get careful, rigorous measurements. So let's look at an example of a patient who was actually enrolled in the SMART trial. This is one of my patients, an 83-year-old woman with severe aortic stenosis, has some mixed mitral disease with MS and MR with MAC, but it was felt not to be the predominant lesion in her. She had peak and mean gradients of 81 over 50 millimeters of mercury, a valve area of 0.56, preserved ejection fraction, and a low velocity index. It was decided with shared decision-making to proceed with TAVR. Here you see her CT summary. She had a small annulus, 350 square millimeters, perimeter of 67, suitable for either a Sapien 23 or a Evolute Pro 26 valve, and had adequate sinus heights, coronary heights, and root angle. She was actually enrolled in the SMART trial, and randomized to a sapien valve. And here you see some of the key CT imaging. I'm not going to belabor this since I'm sure you do this every day for your TAVR patients. Here you see the procedure. This is in a coplanar view. A sapien 323 valve was deployed. You can see a good placement, relatively high, not fully expanded due to the large amount of bulky calcium that you see here in the right and non-coronary sinuses. And here are her data on follow-up. You can see in the upper 2D echoes that she had no paravalvular leak, had nice laminar flow, but her mean gradient in the hybrid operating room at the time of her procedure right afterwards was 5 millimeters of mercury. And on post-op day 1, it was 16, and on post-op day 30, it was 15. And a tripling of her gradient measured from post-op to post-op day 1. We went back and looked at 100 sapien valves implanted at our institution, and this is what we saw, a roughly tripling of the gradient between immediate post-procedure and follow-up. And the reason for that is that there is a low flow state right after the procedure. It's due to the fact that patients have not eaten overnight, they're receiving sedation, some form of anesthesia, and they've had pacing runs. So immediately after the procedure, you tend to see a low flow state with low gradient. The valve area the next day has not changed. They didn't suddenly develop more stenosis. They developed an increase in flow, a higher cardiac output, and that raises the gradient. So it's very important when we look at gradients to measure them in the normal flow state and think about them in that context. So the next question is, we know that the self-expanding valves have slightly better hemodynamics than the balloon expandable valves, but they're relatively small differences.
We do have a problem, right?
I think we have a problem in the internet from Professor Herrmann.
No, but Eduardo, may I suggest that maybe you can start with the case, or Alexandre,
Okay,
as you want, and in case that Dr. Herrmann came in, he can continue the presentation, but I don't know exactly, I'm trying to touch base, and I can.
Yes, in Portuguese, or there are people from other country, Brazil.
Just from Brazil, I believe.
Yeah.
Então, boa noite a todos. Vamos, um problema técnico. Nós vamos inverter a ordem das apresentações. Agora eu tenho o prazer de convidar o Dr. Eduardo Saadi. Ele é professor titular de cirurgia cardiovascular na Universidade Federal de Porto Alegre. É o cirurgião-chefe responsável pelo serviço do Hospital São Lucas, também em Porto Alegre. E ele vai apresentar um caso, Which Size Should We Choose? Nesse webinar de Tavi on Small Anatomies. Então, Eduardo, por favor.
Obrigado pelas palavras, Carlos Manuel. Obrigado, Rui. Obrigado, Juan, todo o time da Medtronic também e da Sbccv pelo convite para participar desse webinar, nesse assunto, que realmente é um assunto muito importante, que tem sido cada vez mais discutido e nem sempre muito valorizado, que é a questão do mismatch ou da escolha do dispositivo de substituição valvar, seja ele cirúrgico, seja ele por via transcatéter. Tá, eu vou começar em português. Vocês, faz favor, Carlos Manuel e Rui, se o Herrmann entrar, vocês me avisem, que aí eu mudo para inglês para ele poder participar da discussão também. Então, esses são os meus potenciais conflitos de interesse. Vou apresentar um caso para vocês de uma senhora de 82 anos com 2 cirurgias prévias de troca valvar aórtica por prótese biológica, por estenose aórtica, uma paciente hipertensa, diabética, que a última cirurgia foi há 5 anos atrás, onde foi implantada uma prótese porcina Biocor número 23 milímetros. Agora ela se apresentou no hospital com insuficiência cardíaca classe 4, e os gradientes que previamente eram 35 de máximo e 20 de médio, subiram para 85 de gradiente máximo e 42 de médio. O orifício efetivo valvar aórtico, que previamente, logo depois da cirurgia, era de 1,3 centímetros quadrados, agora passou para 0,8 centímetros quadrados. E o índice de o orifício efetivo indexado para 0,42 centímetros quadrados por metro quadrado. A gente sabe que abaixo de 0,65 significa uma estenose aórtica grave, ou no caso de uma prótese, um mismatch grave. Ela também tinha insuficiência valvar, insuficiência aórtica grave, tanto transvalvar quanto perivalvar. Segundo os critérios do VARC-3, que foi recentemente publicado, então ela, além de um mismatch moderado, a grave que ela já tinha previamente, ela também se inclui dentro dos critérios do VARC-3 no estágio 3 de degeneração estrutural, ou seja, degeneração estrutural grave da prótese, já com alterações hemodinâmicas importantes. E aqui, só como foi recentemente publicado, eu tomei nota aqui e ressaltei que os critérios para estágio 3 seriam um aumento no gradiente médio mais do que 20 milímetros de mercúrio, resultando num gradiente final maior do que 30, com uma diminuição concomitante do orifício efetivo, ou mais de 50% do DVI, mais de 0,2, ou mais de 40% do DVI, ou uma ocorrência nova, um aumento de mais de 2 graus na insuficiência aórtica transprotética, né, não periprotética, resultando em insuficiência aórtica grave. Então, na realidade, ela tinha todos esses critérios de degeneração estrutural da prótese biológica implantada 5 anos antes. Então, pelo aplicativo que a gente pode calcular o orifício efetivo, então aqui vocês podem ver uma prótese Biocor, que a gente utilizava bastante, agora infelizmente não tem mais no Brasil, uma prótese boa, mas realmente ficava um gradiente mais alto, a gente sabe disso, né, a prótese porcina. Então, nesse caso, o gradiente de pico estimado era 30, o médio era de 20, um orifício efetivo em torno de 1,3. Né? Mas, se a gente considerar a superfície corporal e indexar pelo peso e altura, nós vamos ver que a superfície corporal dela é 1,88 centímetros quadrados, que daria um orifício efetivo de 1,3, indexado de 0,69 centímetros quadrados por metro quadrado. É extremamente importante a gente fazer esse cálculo, porque aqui já essa prótese está praticamente com um mismatch grave. Abaixo de 0,65 centímetros quadrados por metro quadrado é considerado um mismatch grave. Entre 0,65 e 0,85 é um mismatch moderado. Então aqui a gente diria que está na fronteira, antes de qualquer degeneração estrutural, para um mismatch. Então a gente deveria, provavelmente, essa paciente onde foi operada, ter sido colocado um outro substituto valvar ou utilizado uma outra alternativa para que ela não saísse da cirurgia já com um mismatch grave a moderado. Então, essa é a angiotomografia dessa paciente, né? Então, uma Biocor 23 milímetros, tem um True ID, ou seja, um diâmetro interno da prótese, em torno de 20, 21 milímetros, em torno de 2 a 3 milímetros menor que o diâmetro nominal da prótese. E aqui vocês podem ver o que normalmente a gente enxerga, tanto no eco 3D quanto na angiotomografia, que é um espessamento dos folhetos, vocês vejam aqui os folhetos espessados, e calcificação dos folhetos. Então, em 5 anos, essa paciente teve degeneração estrutural dessa bioprótese, e aqui seria o terceiro procedimento, ela já fez 2, e a gente tem que pensar, então, no momento da primeira, ou eventualmente de uma reoperação, tentar deixar um dispositivo que seja adequado ao tamanho do paciente, porque, sem dúvida nenhuma, o mismatch e esses gradientes elevados, eles contribuem para uma para TAVI, para valve em valve, a distância do anel virtual para as artérias coronárias, né, que se chama de VTC, ou seja, Virtual Ring to Coronary, acima de 4 é considerado razoavelmente seguro, vocês vejam que nós estamos bem na fronteira, 4,9 a coronária direita e 5 a coronária esquerda, ou seja, é um VTC limítrofe com um certo risco para obstrução coronária no caso de um valve em valve. Então, esse é o eco transesofágico, Vocês podem ver que existe uma insuficiência aórtica transvalvar, que isso é por degeneração estrutural, e existe esse leak aqui, perto do folheto não coronariano, do septo interventricular, desculpa, o septo interatrial. Vocês podem observar aqui que foi medido, então, em torno de 0,8 por 0,5 centímetros esse leak perivalvar. Então, em resumo, o que nós temos agora é uma paciente de 82 anos, né, feminina, com insuficiência aórtica, tanto perivalvar quanto transvalvar, uma estenose aórtica grave, inicialmente por um mismatch moderado a grave e, mais recentemente, por critérios de degeneração estrutural da prótese por calcificação e espessamento dos folhetos.
Eduardo, desculpa interromper, o professor Herrmann conseguiu entrar de novo, então se você quiser falar inglês.
Ok. Welcome back, Dr. Herrmann.
Oh, I'm terribly sorry. I didn't realize I had lost my connection. Can you tell me where I fell off the webinar?
No, we just decided that we were going to present this case, and then you can comment this case, and then you finished your presentation. Okay. I think the last webinar we were together, I have already presented this case that was structural valve degeneration, right? It was 82-year-old lady with a mismatch, 2 previous AVRs with biological valves. It was a biological valve porcine 23 that the previous EOA was 0.69, between moderate and severe mismatch. And then she developed SVD with paravalvular regurgitation, transvalvular AI, and higher gradient that went from a previous mean of 20 to 42 millimeters of mercury. So we are now in phase of this patient with a moderate to severe PPM with a biological porcine valve, which is non-SVD, and this prosthesis lasts 5 years. The last operation was 5 years ago. Now this patient is in stage 3 SVD with high gradients that will increase mean gradient more than 20, and aortic regurgitation with transvalvular SVD, and a leak that is considered an important leak as well. And now we have to decide what we're going to do with this patient. So you just came back in the right time. I think we can open for discussion. I think you can comment on this case, Dr. Herrmann.
Well, obviously it needs another valve. I think I didn't see the paravalvular leak, so I'm not sure exactly how severe that is and how that enters into this discussion, but we need to treat both, obviously. And this was a 23 bioprosthetic valve, I think you said. So,
yeah.
You know, I think the options are, yeah, it's pretty sizable. So one can plug the leak and then place a new valve inside this in valve. The data suggests that the presence of severe PPM or close to severe PPM in the surgical valve is a very potent predictor for high gradients and worsened outcome post-TAVR, particularly if you utilize a small valve such as a balloon expandable valve as opposed to a self-expanding higher hemodynamic lower gradient valve.
So this is the true ID 2021. This is the CT with the thickening and calcification of the leaflets. The VTC was borderline between 4 and 5. And this is the AI, transvalvular and paravalvular. This is almost 1 centimeter by ½ centimeter, the leak. So this is the valve-in-valve app. So she had an BioCore 23, which I agree in this case it's better to put a self-expandable supravalvular device that will lead a gradient that was already high, and probably can take this patient back to the previous gradient that she had. So as you suggested, first we did this case with TE to facilitate the placement of the plug on the paravalvular leak. So the first step was to cross the leak here in the non-coronary sinus. Here in Brazil, we don't have the AVP3, so we just have the AVP2 plug. So we used an AVP2 plug. Here you can see the plug. And then we did an angio after the plug. It was, there was an improvement of the AI, just valvular, not more paravalvular. Here you can see on TE, almost a complete resolution of the paravalvular leak. And then we decided to go with a 23 Evolut R TAVR to put a bit lower because of the coronary arteries. And this is the final result with the plug and the valve placed. Here the result on the TE, just a very trivial AI, and the gradients went back to the previous. It was 20 before, now, as you said, it's usually lower during general anesthesia, so it was 19 the next day, and trivial AI. The question is, what's going to happen with this valve that the patient still has a gradient higher than we would like to see. And here we have created the educational site and on Instagram that everyone can subscribe to receive information on structural heart. So thank you very much for your attention.
That's a very nice result, and you really did this patient a great service with that approach. You know, she is 82 and she's already had surgery. You know, her outcome may not be quite as good as somebody who was having an Evolut the first time without a prior surgical valve, but hopefully she'll get a few good years out of this. And, you know, I think her outcome will not be quite as good as if it was a bigger valve and a native, but hopefully she'll get good relief for a substantial period of time. So I think you did her a great service with that.
So when you're not I started considering that we are talking for surgeons. That is very important when we do the first operation to try not to leave any mismatch, not even a moderate mismatch. So we should try to do everything, annulus enlargement, or maybe decide another strategy to do the first procedure expecting the lifetime management of the patient with aortic stenosis. And I think we as a surgeon, we are not doing a very good job, because in many centers, even in experienced centers, we see 21 millimeter biological valves in bigger patients. So we should try to do a simple operation that is annulus enlargement, and give the patient a chance for future treatment with long-term expectancy.
So in this regard, Eduardo, should we think about not doing an open heart for these patients and go ahead with self-expandable TAVR in these guys or ladies with small annulus, instead of doing a larger procedure to increase or enlarge the annulus? Should we think of doing first-time TAVR? It's just an open question.
Before the final answer of Dr. Herrmann, I would like just to give my impression that it depends on the age of the patient, Alexandre. If it's a young patient and we start with TAVR, we have to plan the next procedure. What will be? Will be SAVR, then to explant. TAVR is more complex than the first operation, as you know. Or then you go TAVR in TAVR, and what's the life expectancy of the patient and the expectancy of the prosthesis.
Yeah, I agree entirely. I think we know a lot already about TAVR and SAVR. We know much less about TAVR and TAVR. The risks of coronary occlusion, the risks of having a smaller valve inside a smaller valve are all things that we don't really understand yet and don't have good long-term data on. So I think for young patients, getting a surgical valve that's large enough to accept a TAVR gives me 25-year confidence that I have a way to treat that patient. Whereas I'm not sure I have that same confidence with TAVR and TAVR for that length of time at this point. So I don't know how much of my talk I ended up being able to give before my internet gave out. Do you?
You just was stopped by the internet in question number 2. That was your last slide.
Question number 2?
Yeah.
All right. Shall I go back there and
I appreciate it.
So the question was, how can small gradients make a difference? And this is data from the Australian National Echo Registry looking at more than 6,000 patients who had SAVR and TAVR. And what you can see is that the adjusted age and sex adjusted 1-year mortality starts going up as soon as the gradient exceeds 20. 1-year mortality, 38% and 40% compared with 30%. And if you look at 5-year mortality, the adjusted hazard ratio goes up again around 22 millimeters of mercury, with a 40% increase in adjusted hazard ratio for all-cause mortality. Some data that compares core valve and surgery in what is essentially a similar comparison to what we would think of for self-expanding and balloon expandable valves. And what you can see is relatively small differences in gradient at 1 year, 3 or so millimeters of mercury, translate into important differences in the mean gradient more than 20 and in the effective orifice area of severe PPM. So even though there was only about a 3 millimeter surgery in this comparison, the mean gradient was 9% versus 2% of more than 20, and the effective orifice area of severe PPM was 18% versus 5%. So even small differences can translate into important outcome differences. Sorry. Just making sure you can still hear me. Is everybody able to see my slides and hear me?
We are able to see it, but it's got a black spot on it, and we're losing from time to time your talk. Okay, now the black spot's gone.
Now it's okay.
Okay, so this is some data was just presented by O'Hare at ACC looking at hemodynamic valve deterioration, again, in a group of TAVR patients from the randomized trials and SAVR patients compared, again, small differences in gradient, but these translated into important differences in hemodynamic valve deterioration of more than 10 millimeters at 5 years. So almost doubling in the surgical population, hemodynamic valve deterioration with only a small difference in mean gradient. And when you look at the predictors of hemodynamic valve deterioration, it was larger mean gradients and severe PPM. And most importantly, when you look at the correlation of hemodynamic valve deterioration and mortality, it's concentrating on this middle part of the table, you see a 3-fold excess hazard ratio for all-cause mortality, cardiovascular mortality, and valve-related hospitalization in patients who had hemodynamic valve deterioration correlating with 5-year mortality. So small differences in gradient translated into larger differences in hemodynamic valve deterioration, and those were correlated with 5-year mortality. So this is sort of the rationale for why we think even the small differences in gradient that we'll see between self-expanding and balloon expandable valves in the SMART trial will be important. How does PPM fit into this category? Is it the same as residual gradient? Well, we know from the surgical world that severe PPM is associated with a 2-fold increase in mortality and a 6-fold increase in cardiac mortality. Is the same true in the TAVR world? Well, we know the incidence of severe PPM is less in the TAVR world. This is data from the TVT registry of more than 60,000 patients that we studied between 2014 and 2017. And you can see that the adjusted hazard ratio for 1-year mortality was significantly higher if you had severe PPM. And I'm sure some people will look at this and say, well, that difference is relatively small, only about 2%, but that's only 1 year. And these curves are clearly diverging still at 1 year. So severe PPM is sometimes something we have to look at more in the long term. Are my slides and talk still coming through okay on the internet?
Yes, sir.
Yes, sure.
Good. So when we look at the predictors of severe PPM in this study, the 2 most important ones were female gender and small valve sizes, and these are correlated together, as you'd expect. This has now been confirmed in a very recent study just published in JACC Cardiovascular Interventions from an Italian multi-center registry of 445 patients with a small annulus, less than 400.
It's gone again.
So I have to apologize. My internet connection does not seem to be very strong. It keeps blocking me off. I'm back again. Hopefully I can get back to my slides here. Looking at an Italian multi-center international registry of patients with a small annulus, 90% of them were women, and they compared supraannular valves, mostly evolute, some accurate neo, to intraannular valves, mostly portico, some accurate TA. Severe PPM was present in only 9%, but it was predicted by having an intraannular prosthesis, and it was associated with a higher adjusted all-cause 1-year mortality, 4-fold higher. So again, you see that small annulus magnifies these differences in relatively small amounts of gradient. So supraannular valves had better gradients than intraannular self-expanding, and we know that they also do compared to intraannular balloon expandable valves. If you look at the core valve registry from TCT, from the TVT registry, the incidence of severe PPM was less. In my study of the TVT registry, severe PPM was 12%. If you look just at the Evolute platform and core valve platform, it's only 5%, suggesting that some of that difference were Edwards valves, and it did not translate into an increase in mortality at 1 year. So again, if you have a small incidence, it may not be visible at 1 year, but I think it will be visible as you go further out. So why is the incidence of PPM, why does it vary after TAVR? Some of it has to do with how the gradient's determined, echo versus cath. Some of it has to do with how you calculate the effective orifice area. Is it measured or predicted? The timing of measurement, are you looking right after the procedure when you're in a low flow state or later, and whether or not you're correcting it for obesity. And then when you look at the effects on outcomes, it's also a little conflicting because these differences, as I mentioned above, but also incomplete correction for confounding variables such as paravalvular leak, underpowered analyses, if you're only looking at a small number of patients, and limited follow-up, it may take a little longer to see those effects than 1 year. So are these differences accentuated in patients with a small annulus? Well, first question there is, how common are small annuluses? And they're very common. In SAVR world, as was mentioned already, a lot of 21 millimeter valves go in, 20 to 40%. If you look at the important randomized trials, and these are the intermediate risk trials, so this is Partner 2 and Tavi, and if you look at the low risk trials, Partner 3 and Evolute low risk, what you see is about a third of patients qualify for small balloon expandable valves, and about a fifth of patients qualify for small self-expanding valves, 23s and 26s. And those differences are higher in Southern Europe and Asia, higher if you do TAVR and SAVR, and several-fold higher in women, who again make up the majority of these patients. This is the Echo Core Lab study that got a lot of attention. 3 Echo Core Labs combined their data and looked at effective orifice area, gradient, and DVI in different size annuluses. And these are the lowest 2 quintiles pictured on this slide. And what you see is self-expanding valves had larger effective orifice areas than balloon expandable valves, had lower mean gradients, and had higher DVIs. Now, this is the data that demonstrates these important hemodynamic differences between self-expanding and balloon expandable valves. And so that's the rationale for the SMART trial, a small annulus trial randomizing patients to the Medtronic platform or the Edwards platform. The qualification for entry into the trial is shown here, 430 square millimeters or less on CT. 700 patients will be randomized one-to-one stratified by sex. This is going to be the largest head-to-head trial ever done in the TAVR world with contemporary devices. It's prospective, multi-center, international, randomized, 90 sites in Canada, Europe, the Middle East, and Asia, and the United States, and has two co-primary endpoints at 12 months. The first is a clinical one, death, stroke, and rehospitalization for heart failure. And the second is a hemodynamic one, bioprosthetic valve dysfunction. The primary endpoint is at 1 year, but we will have annual 5-year follow-up, so we'll be able to look at the effects of these things on durability. I have the privilege of chairing this study for Medtronic, who is the sponsor. My co-PIs are Roxana Mehran and Didier Cheche. It's an all-comers trial that includes bicuspid valves. The only criterion is that patients have to be suitable for transfemoral TAVR with both devices. And then we'll have the usual core labs, clinical event committees, data safety monitoring, et cetera, of a large-scale randomized trial. We were able to enroll the first patient in April at my site, and this trial is ongoing and now spreading to many more sites. I want to go into just a tiny bit more depth on the second co-primary endpoint, bioprosthetic valve dysfunction. This trial is powered for non-inferiority of the clinical outcome and superiority of the self-expanding valve for bioprosthetic valve dysfunction. That includes these 4 or 5 characteristics. These were first suggested by Dave Capodanno and then subsequently adopted in the VARC-3 criteria. And it includes these 4 categories: structural valve deterioration, which is hemodynamic. And we chose the definition of a mean gradient of 20 millimeters or more, which has been found in many studies to be predictive of worse outcomes. And this will be assessed at 1 year. Non-structural valve deterioration, which is severe PPM and more than moderate or more aortic insufficiency, and then thrombosis, endocarditis, and aortic valve reoperation or reintervention. We have a number of powered secondary endpoints that will be important, as well as a host of unpowered secondary endpoints. So largest head-to-head trial, 700 patients, we're going to have a ton of data to compare these devices that will hopefully inform practice, that will allow us to choose not only TAVR over SAVR for the right patients, but which TAVR prosthesis for which patients. And as a teaser of the outcomes, I show you this study that was just presented at EuroPCR from Tom Modine in France, looking at a pooled cohort of women who had a small annulus in the Evolute database. And they compared TAVR patients to SAVR patients. So this is not TAVR to TAVR, it's TAVR to SAVR, but with a small annulus. And what you see for hemodynamics are essentially what we hope to see in the SMART trial or expect to see, which is slightly larger gradients. In this case, in SAVR, we're going to substitute in your minds the balloon expandable valve versus Evolute's platform at 1 year, 12 versus 8 millimeter, so 4 millimeter difference in gradient. Look how that translated into our second co-primary endpoint. And this is the same endpoint as we see in SMART. A composite endpoint of bioprosthetic valve dysfunction at 1 year occurred in 11% of the TAVR population and 30% of the SAVR population. Hemodynamic valve dysfunction, 4% with TAVR, 19% with SAVR. Non-structural valve dysfunction, PPM and AR, 9% in TAVR, 18% twice as frequent with SAVR. So this is sort of a surrogate for what we might expect. This is a non-randomized comparison versus SAVR. We're doing a randomized comparison of self-expanding to balloon expandable valves. And so we're very excited that hopefully in about 2 years, we will have enrolled and then we'll be able to follow up shortly thereafter this important head-to-head trial that will influence practice in hopefully a positive way for our patients. So I'll stop there and be happy to answer any questions that you have. Hopefully you got to see all of that before my internet crashed.
Do you have any questions from the audience in respect of this, what Professor Herrmann just spoke?
I'd just like to ask one question for Dr. Herrmann. he pointed out that echo, as we know, is not the ideal method of measuring the real gradients. As we cannot do a cardiac cath in the patients because it's invasive, what else would you suggest to follow up this patient and evaluate and to grade exactly the degree of aortic stenosis and or residual gradient?
Well, I think echo is not perfect, but it is easy to do, it's reproducible, and we can follow it over time. So I think it is still the gold standard for how we follow valves. We've been utilizing it for decades. We follow surgical valves with this. I don't think high gradients are false. One could argue about whether a gradient is 6 or 9 and whether that's a real difference. But I think when you start to get to gradients of over 20, they are real and they reflect valve dysfunction, and I think they are important. Another thing we can do, and which we are going to do in the SMART trial, is we're going to also do exercise at 1 year in a subset of patients and look at the effects of exercise-induced larger increases in gradient, which we think will be even more important and as a differentiator between the two devices.
Okay, we have a question from the audience. It's from Dr. Gustavo Judas. He would like to know if in some publications that have shown that the size of the valvular ring is a risk factor for mismatch in surgical, in SAVR, so surgical replacement. Is that also for Tavi? Is that also a risk factor?
I'm not sure I understand the question. You mean the size of which valve we're using, which size valve, whether we're using a 23?
Oh, the size of the ring, of the first ring, of the primary ring of the patient is a mismatch for all the times for the surgical replacement of the valve. But it seems to be that the gradient when you change for Tavi is not as much as important as it is for conventional surgery. Is that correct?
Well, it is true that because there's no ring, there's no surgical sewing ring, that in general, the incidence of PPM is less with TAVR than it is with SAVR. The falling incidence of severe PPM in the TAVR world is really multifactorial. Part of it is that TAVR has better hemodynamics than most surgical rings because there's no surgical ring, and you can get a little larger effective orifice area. Part of it's definitional too. We've been changing the definition over time of severe PPM as we've started to correct for obesity, as we've changed the lower limit of severe PPM from 0.65 centimeters squared per meter squared down to 0.55 in obese patients. So all of those things sort of go in together along with how you measure it and how you calculate it and when you calculate it. So I think there is a decreasing incidence of severe PPM, but it's also true that when you have severe PPM, which you will have much more frequently in a small annulus, it is going to affect outcome.
Okay. I would like to know one of the things, in this study that you started, SMART study, you've excluded patients who had already a previous operation for valve replacement. Is this because of the Vivus trial that was done before, or because mostly the ring is still small rings when you do it valve in valve? It's probably because of the other study done?
No, it isn't because of the other study. It was because it would, in some ways, overwhelm the rest of the data because the gradients are so much higher. There's also differences in technique for valve in valve. If you put a sapien valve in, there's a tendency to fracture if the gradient is high. Fracture has its own complications, including a risk of stroke. We don't know that much about the long-term outcomes of fracturing. And so we were concerned that there would be confounders that would change the discussion from the hemodynamics to the technique. And so we didn't want to contaminate the study with those sort of differences in how these valves are implanted. Okay,
thank you. I think I've got a question from Dr. Fernando Rocchetti to Eduardo. He asked you why Tavi was lower, you deployed it lower. Is that because of the plug you used before to not obstruct the way of the ventricle, the outflow?
Now, Fernando, the VTC was borderline. It was between 4 and 5 for both coronary arteries. So when the VTC is borderline, we prefer to put the prosthesis a bit lower. And we think that the risk of coronary obstruction reduces a bit.
Sure, you're not pushing the leaflets on the surgical valve out quite as far when you do that, and that may be an advantage. The alternative, of course, is to do a basilica procedure to split the valve leaflet before you put the TAVR prosthesis in.
Now continuing, I'd like to introduce our dear friend from Rio de Janeiro, Dr. Alexandre Colafranceschi. He's a cardiac surgeon at Hospital Procardíaco and National Institute of Cardiology of Rio de Janeiro. He's also assistant professor at Unirio. So, Alexandre.
Thank you, Carlos. I wish I can thank the society for the privilege of being here. Congratulate my colleagues, Dr. Herrmann, and welcome all the audience to this discussion tonight. It's been coming out from the case Dr. Eduardo presented and from the talk Dr. Herrmann generously gave to us. I wish I can talk a little bit about a case. This is an ongoing case. I did this TAVR 8 days ago. This is a 82 years old female. She was admitted beginning of June due to short of breath, productive cough, and low O2 set. She has a past medical history of diabetes, hypertension, dyslipidemia, hypothyroid, COPD, breast cancer with a radiotherapy, chest radiotherapy. She is status post cabbage ×3, and she has had a stroke in 2016. Very diseased lady. She was admitted awake, but not oriented. Her heart rate was 78, blood pressure 108/54. She was afebrile. She is a very big lady, 1.6 meters, 95 kilograms, an IMC of 37.1, obesity. She had a regular rhythm, S4, and hollow systolic murmur in the left lower border, and also a murmur at the aortic focus, a systolic rejective murmur there. She had coarse crackles bilaterally, and she was saturating 98 on 5 liters of oxygen at this time. Well, her labs shown like an inflammatory reaction on CRP of 8, although white blood cell was 7.2. Troponin was 95.5. The ABG showed a hypoxic and a little CO2 retention, and she was borderline on her lactic acid. Her shed a lower lobe pneumonia, and there was also a ground glass on the lung fields bilaterally. Her PCR for COVID-19 was negative. The initial impression was she had a pneumonia and a septic state. So this is an 82 years old lady with previous heart compromise due to cabbage, and she was admitted with heart failure, pneumonia, and sepsis. Her initial echo showed a preserved LV function, and LA was enlarged. She has an elevated EE, like showing high diastolic, intraventricular diastolic pressure. There was a moderate to severe MR, and aortic sclerosis. They were not able to evaluate the transvalvular gradient at that time, a mild AR, and then a dilated RV with systolic pulmonary pressure of 70 with a severe TR. So this was due to radiotherapy. She had a tricuspid lesion due to this previous breast cancer treatment. She was under the pulmonary angiography CT to look out pulmonary embolism, and it was normal. The patient did not improve after the antibiotics. She was failure, systemic and pulmonary congestion, refractory to IV Lasix. She did not tolerate vasodilators. She was started on Murinon. And we put her on a TEE to evaluate better her aortic valve. And the aortic valve is shown there, a calcific prolific aortic valve with preserved LV function, as I mentioned before. And the transvalvular grade time was 28. There was a mild AR, as you can see in your right panel there. So we have a aortic stenosis, 0.8 of aortic area, 0.8 centimeters square. She is a big lady, probably almost 2 in terms of square meter. So we had an index aortic valve area of 0.4 and a low gradient, transvalvular gradient. So we thought about this lady was in heart failure due to a low gradient, low flow aortic stenosis, low flow state. And we did an angio CT and a calcium score. The calcium score was a little over 1300. And we have a really small annulus with 60 millimeters as a perimeter, almost 300 millimeters square area, and 18.919 millimeters the diameter derived from the annulus. Very small annulus. We suppose this was a true aortic stenosis, severe aortic stenosis. So we end up sending her to a TAVR. We also did the measurements on the TE. It didn't show much difference from what we have gotten from the CT. You can see in the right upper side here, the diameters from 1.8, 1.9, 2.58 area, 5.82 perimeter. So those were the echo measurements. We did a straightforward transfemoral sapien 3, number 20 valve, as you can see. There was a small paravalvular leak. You can see transgastric, right lower end. We did a pause implantation valvuloplasty, and the paravalvular leak pretty much vanished, and we end up with this transvalvular gradient of 14 millimeters of mercury, transvalvular gradient after TAVR. She's still there, and these are my last slide showing the post-operative period, the difference we observed on the Swan-Ganz. The cardiac index went up from 1.7 to 2.4. The systolic pulmonary pressure came down from 70 to 55. Diastolic pulmonary pressure 28 to 18. The capillary pressure 22 to 11, and the CVP 15 to 5. So this is probably 2 to 4 hours after intervention in the ICU. So I brought this case. She is still in the hospital. Was a very tough case, decision in terms of decision making, if we should go or not for the TAVR, and which prosthesis to use, and the results are there. So I brought for our discussion here. Thank you for the privilege to present this case, and I'm open to discuss. And I will be glad to hear your comments as well.
Well, I mean, I think you should be congratulated on rescuing a patient who was otherwise circling the drain and obviously in a mortal situation. You know, I think nobody can argue with you choosing a Sapien versus an Evolut here. It's just, you know, for dealer's choice of what you're most comfortable with, what are access allowed. And the goal here is not to think about long-term durability, but 1 week durability, can we get this patient out of shock and out of the hospital? So I think whatever you can do and whatever's easiest in your institution and your familiarity is what you should choose. I would guess, though, that her gradient is no longer 14. As her output went up, it's probably in the mid-20s or higher. These 20 millimeter valves with normal flow usually have gradients in the mid-20s or higher. But again, that goal here wasn't long-term durability, but getting out of the shock state. And the only other question I'd have is if her MR got enough better, or whether you would, sometimes in patients like this, we've considered either doing MitraClip with TAVR or MitraClip after TAVR. If MR stays very severe, but maybe it got better. I also think it's, when I see patients who have both AS and MR and this question comes up, I always think it's easier to treat the AS first and see what happens to the MR. I think it's harder to do a MitraClip on a patient with severe aortic stenosis. And I think the TAVR is still almost an easier procedure than a MitraClip.
Agree.
Alexandre,
Yes.
congratulations for the presentation, the great case, diagnostic challenge, severe pulmonary hypertension with a tricuspid insufficiency. I think it was a very well conducted case. In my experience, I don't feel very comfortable to use a Sapien 320. I don't know what do you think? I agree with Dr. Herrmann. Here, the main goal was to save the patient's life and to improve quality, and I'm not just talking about valve durability, but maybe gradients that Dr. Herrmann will show us in the SMART trial what is the real consequence of this gradients difference. But between an Evolut R 23, probably in this case, I don't remember the perimeter, but it may be a 23 or a Sapien 320. What do you think that, why to choose a balloon expandable in small annulus?
That's a good question. We use both valves. I use a lot the Evolut R for valving valves, but for primary procedures, I tend to use the balloon expandable ones. In this case, particularly, she had a renal failure, and we use a lot less contrast during the procedure when we are able to plan in advance when we use the balloon expandable ones. So we pretty much do all the procedure with one shot, the echo guide, everything else. So that's one of the reasons we have chosen to use the balloon expandable one.
Okay, we have an important question from the audience. I would like to see all the three speakers answering this important question. What is the best time to access the transvalvular gradient after TAVI? To know the real value of this transvalvular gradient, starting with Dr. Howard, please.
Well, it's almost easier to answer the question in reverse and to say the wrong time to measure it is right after the procedure. Almost any time after that is probably okay. Our data suggests that a one-day measure is similar to the 30-day, and that those values will help to predict what will happen at 1 year and over time. But a discharge or 30-day echo, I think, is more representative of the patient's true state if you're just looking at the gradient than measuring it in the hybrid operating room or in the cath lab, where I think too many other factors are affecting it, the hemodynamics, the low flow state of sedation, being NPO, having a pacing run, and then maybe not even getting the maximal gradient because you're not rolling the patient and you're getting the gradient from a suboptimal view. So all of those things, I think, factor into the gradient being less reliable right after the procedure.
Yeah, that's a great question, sir. Thank you for those comments as well. So I was involved in the case in the initial phase due to the mitral regurgitation. But the LV is normal. The mitral has no structural disease. And we did an echo with inotrops, and the mitral valve leaks more the highest the pressure gets. So was a dynamic mitral regurgitation state depending on the blood pressure. So after the TAVR, we got mild to moderate MR. It's not being a problem to manage with vasodilators now.
Eduardo, please.
Yeah, we do the same. We do an echo next day or maybe 2 days after the patient has staying 2 days in the hospital. And then in the first 3 months, we do it as a baseline for the follow-up of the patient. And then every 6 months or yearly, depending on the patient status. But usually before discharge and in the first 3 months. This is as a baseline.
Alexandre?
Yeah, I think we have learned from Dr. Herrmann about that, and we have realized the differences between intraventricular measurements and the echo. Our facility is really echo guided, so we gave up of doing the interventricular transvalvular gradient in the OR. So we've been measuring everything through the echo. Pretty much we do an echo for discharge, and that's our benchmark.
Professor Rui, I think we are in advance in time. I think I would like to thank the Brazilian Society for inviting me to moderate this important webinar with you. I would like to thank Professor Howard, Professor Eduardo, Professor Alexandre, and also to thank Medtronic for sponsoring this important webinar.
I want to thank you as well for allowing me to participate, and I apologize for my issues with the internet, but hopefully we were able to get through it, and I look forward to interacting with the Brazilian Society in the future.
Thank you
very much. Next time, personally in Iguaçu Falls, Dr. Herrmann.
Yes.
It has been a long time you've been there.
Then I won't have internet problems. So yes, I would look forward.
Oh yes, you don't know.
Okay.
All right.
Good night.
I'll end this thanking all of you. It was great, I think. We had a full audience until now. Only 2 people left from the beginning. Problems with the internet are always the same. The most valuable phrase nowadays is, are you listening to me? In all webinars that I received. I would like to thank Juan Gaspar in name of the Medtronic for all his effort. I hope you all enjoy it. I would like to thank the society and also Merit and Sandra for being here, and from Medtronic Brazil. Thank you all. We hope to see you sometime. And if there are any questions from the audience still, please send us to us and we'll send it to the speaker so that it can be answered. Thank you very much.
Great.
Uma marca histórica na substituição da válvula aórtica transcatéter.